Hello, do you hear me? Well, I was thinking how to address to you, with ladies and gentlemen, I don't know, dear guests and dear hosts and so on. But please allow me to address to you with a simple dear friends. Welcome at this panel, which I have the honor to moderate, called Virtual Institute for Health and Wellbeing Public Conferences. And in this afternoon, we will have a series of very interesting public conferences. I will announce each of them at the right moment, but for this specific moment, please allow me to have some specifications related to the organization of this panel. We have, it's a hybrid panel, on-site and online. And we have, in this respect, two categories of communications. Our colleagues who are here with us, and we are saluting them. They are here at this presidium. And also we have remote colleagues from all over Europe. And because we have 1, 2, 3, 4, 5, 6, 7 conferences, I have to exercise my authority as a moderator and to put some time limits. Now it's a very thin line between a moderator and a dictator. So, I'll do my best not to cross it, but for organizing this session, I was thinking about 10 to 12 minutes for our colleagues who are on site, this including eventually questions, and about 10 minutes maybe for our colleagues who are online via Zoom, I guess. Now, because it's not important what I have to say, but it is essentially important what our colleagues have to say, please allow me also to announce a small change in the order of the communications, because here we are two from the University of Iași, Romania. Me, my name is Iulian, Damian, and my colleague, Professor Daniela Soitu. Please allow us to present in the end of the session. From we don't want to discriminate anybody, being two of us from the same university. So let's start, and we'll start with a very interesting communication. I'm sure that the communication will be as interesting as the title is. Artificial Intelligence and MRI against Brain Cancer. And I'm inviting our colleague, Professor Christine Fernandez, the Vice-Rector of the University of Poitiers, to introduce us in the subject. Please, Christine.
Hello, everybody. Do you hear me? Perhaps I can keep the mask. So I'm not from Salamanca, but from Poitiers. I'm very happy to be there with you to present you some aspect of my other life, because I'm Vice-Rector in charge of International Affairs, but I'm also a researcher. And I will present you some works we have made in the laboratory that is common between the CNRS, National Center of Research in France, Siemens Company, the University and the Hospital of Poitiers. And the idea is really, I hope that some one of you will be interested by what we do in this common laboratory.
Recording in progress.
And of course, you will be really welcome if you contact me after this presentation. So, as I said, my colleagues, I will present you some results dealing with artificial intelligence and MRI for glioma GLADE. And so I will present you very quickly what is glioma, the concept of biopsy, then virtual biopsy. I will present you what is high-field MRI, and then we can explain what is the virtual biopsy applied to glioma grads thanks to artificial intelligence and MRI. And then I will conclude. So, okay. Yeah. Okay, so what is glioma? Glioma is the most common cancer of the children and the young adult, and is characterized by its grade. The grade is the womb classification. The last one has been given in 2016 with integration of genetic component. And we have basically two classes, the low-grade glioma, that's grades 1 and 2, and the high-grade glioma, grades 3 and 4. And a low-grade glioma has a slow progression, is asymptotic finally. And when you look at the image, you see some diffusion in the tissue. And the opposite, high-grade glioma have a rapid progressions, they are very aggressive, and they present a necrotic earth. And when you diagnose a high-grade glioma, the chance of survival are very reduced. It's why we need to, as soon as possible, diagnose a glioma. And for that, naturally there's a biopsy, a brain biopsy that is made by taking a fragment of tissue. The problem of this aggressive operation is that we have a local substantive for the global informations that give you the evolution, but just at a time t, and you cannot reproduce this exam a lot of time because it's an invasive and painful step. So to avoid all the risk, the idea is to avoid brain biopsies as often as possible. It's why we use virtual biopsy, and that has been allowed by the fact that in the past 15 years we have a lot of imaging techniques in 3 dimensions, like ultrasound, like vibrational optical current tomography for skin cancer, and also magnetic resonance imaging. And finally, if we look at the evolution of MRI, the last years, we have now high-field magnetic resonance, MRI at 7 Tesla. In Europe, there are very few 7 Tesla MRI. There are around 20 in the world. And in France, we have 3 7 Tesla MRI, one in La Limone, in Marseille, another one in the CEA in Saclay. But these 2 MRI are just for clinic. Thank you so much. That is to say that we can have a lot of patients with real disease that are coming for an exam in the 7 Tesla MRI. And this 7 Tesla high-field brain MRI allow really to have new informations about neurodegenerative disease. And we have, of course, anatomical information, but we have also other kind of modalities like diffusion imaging, perfusion, like signal, which is magnetic resonance spectroscopy. And in fact, at the end, that give you really information about the metabolism of the cells. Here you have some example of anatomical sequences. If you are familiar with this kind of applications, medical application, of course, you see T1 contrast, T2 flares, and generally the graduation of glioma is made only with these anatomical sequences. But we can add information of diffusion that give you information about the connections in the brain, as you can see there, and we can reconstruct the fiber finally with tractography. You have also information of perfusion that really give the information about the blood, and so the functional aspect of the brain. And we have also something we call spectroscopy, and that give you the metabolism of some cells. You can examine the behavior of some metabolite like colite, lactate, glutamine, lipids that are really significant of the behavior of your brain. And that gives you a real informations of normal or abnormal behavior of the brain. You really have information about the metabolism of the cells. It's why it's so interesting. Here you have finally a summary of all the informations. As I said before, high spatial resolution images for the anatomic information. You can have with diffusion MRI the study of intracerebral connections. With the perfusion imaging, you have the study of the subcortical brain activity. And then with the spectroscopy, you can have the signals, or you can reconstruct an image that give you really the information about the cell metabolism. So with this multimodal high-field nuclear magnetic resonance assessment, you can have a non-invasive examinations that give you a better description of the behavior of the brain, and so a description of the glioma. And in parallel of that, you well know that deep learning now is showing very good result in many areas of computer vision. So the idea is to use the specific data of multimodal MRI with deep learning process to go to a real virtual patient biopsy with a high predictive value. So now I can show you some result for low grade or high grade detection. To begin, we have to train a neural network, and to train this neural network, we build a database. The first database we used was made with 285 patients that present a glioma at the hospital of Poitiers. They all have an exam in the 7 Tesla MRI. They have also a confirmation with an histological analysis, so they have a real biopsy. And then the first database we used was composed by 75 low-grade glioma and 210 high-grades. And 33% of this database was used to train the network to construct the different weight in our convolutional neural network. So I have no time to explain you which kind of neural network we use, but of course you are free to contact me after that. I just want to present you some results of the literature. If you look at some results by the past, you have in yellow some result with a convolutional neural network, but using only anatomical information. So you see we have good result between 84 to 55% of accuracy. But if you had multimodal informations, you can also see that with other machine learning systems, other systems than neural network, you can have better scores, as you can see with support vector machine, for example, and multimodal information, you have more than 95% of accuracy. And our first result was 96.5% of accuracy. That is really a good score with CNN, which name is ResNet 101. So nowadays, we are increasing the size of the database. The last result we have are even with a best rate of accuracy. We are also developing method for learning on small numbers and unbalanced number of data for the training of the neural networks. We use what we call reinforcement technique or learn prior technique. And we also work on the intelligibility of the systems for the user, because it's very important for the physicians to understand how the neural network is formed, to perhaps imagine some connection between different informations that he never imagined. And for example, when we look at the construction of our network, we see that there are no thing dealing with the diffusion ADC information. But when you look at the ADC imaging, at the left is low-grade glioma, at the right is high-grade glioma, and obviously we see a difference. But when the network builds its connection, it doesn't used finally this information. So we have to work again to better understand what is taken into account by the machine learning system, and to go to a better prediction of the evolution, to propose to the physician the best choice for his patient to hope the best survival for him. So to conclude, we can say that nowadays with ultra-high-field MRI, we can have the detection of very small details, totally invisible in conventional MRI. Conventional MRI that are generally 1.5 Tesla. Then we can go to a very good performance of virtual biopsy for early diagnosis and monitoring of brain tumors, but also of a lot of degenerative disease. We also work on Parkinson, on Alzheimer, on Hutchinson, on Machado disease with our Portuguese colleague. And we can see that neuroimaging and neurosciences are currently experiencing a really revolution due to this very high magnetic fields imaging, due to the growing of deep learning and artificial intelligence method. And all this allow to map the human brain on a scale never before possible. That help radiologists in their diagnosis and prognosis, and that allow what we call 4P medicine, that is to say a predictive, preventive, personalized, and participative medicine. So thank you so much for your attention. Of course, you are welcome in Poitiers. You can come to the hospital in our nice building. At the ground floor, you have the MRI machine, and at the first floor, there are the doctors and the researchers team. So you will be welcome in Poitiers. And I just finished with this slide that explains finally the aim of this I3M laboratory, multi-organ, multi-core metabolic imaging. And now I'm waiting for your question, now and later by mail if you want. Thank you so much.
Thank you very much, Professor Christine. Well, it is usually the moderator says some words about the presentation, but now let me say it, talking about myself only. I really need a dictionary. But anyway, thank you very much, and we are very glad that inside the Virtual Institute are happening such in-depth things in matters of research. Yeah. Thank you very much for everything you are doing for your university, for the University of Poitiers, but for what you are doing for all human beings in the future at least. Thank you very much.
Thank you so much.
Thank you. Okay, and we have a question. Yeah, so, please, Marina. Is it on?
So you were mentioning that one of the greatest advantage of using this technique is that it's not an aggressive approach. We avoid the biopsy, right?
Yeah.
So my concern is that taking into account the glioma, the grade number 4, the first treatment is going to be surgery. What is the main advantage of using this? I mean, I understand that metabolism will be an advantage, but somehow you have to go to surgery, to do biopsy, to do the genomic studies, to do the specific treatment depending on the genetic profile. So for you, in that particular...
In fact, what we hope is to map the information from the imaging, and we hope that the imaging show us a low grade of tumor. And then we had some information dealing with genetic information, other physiological informations, some elements dealing with the life of the patient, something like that. And then the artificial intelligence can produce a diagnosis about the future of the patient. And what is very important is that usually they need a resection. So that's another part of the story, because we also help the neurosurgeon to prepare his surgery, to make the balance between, during, and after the surgery. But what we try to do is really to, after a surgery, to really predict with the information we have with the height field MRI and with other genetic information to predict the recidive, finally. And that's why the metabolistic information are really, really important. Because sometimes if you just use anatomic information, so sometimes you have two patients that have the same surgery, finally, at the same time, with the same grade, but after 6 months, one will have a recidive and the other not. And so the idea is really to study the metabolic informations to better predict which one has a risk and which one has to have, for example, exams more often than the other, finally.
Thank you very much.
Thank you very much again. Well, that's happening when two medical scientists meet. Well, now please let me introduce Professor Marina Holgado Madruga, who both from our host from the University of Salamanca. Please, Marina, the floor is yours.
Oh, yes, for sure. Hello, good afternoon, everybody. Like he mentioned, my name is Marina Holgado. I am from this university, and I'm going to present the final project, the final degree project of the student, Sara Gonzales, who was a student from the School of Nursing here in Salamanca. So who would like to take a bath in the fountain of eternal youth, like it's shown in this painting? As you can see here, we have these old ladies with these saggy breasts who will take the bath here because they are looking for the eternal youth. And then they will become as this young lady. So it seems like this is a painting by Granach and is exhibited in the State Museum of Art in Berlin. And it seems like this concern about reaching the eternal youth is nothing from our time. It just comes from old times. Actually, this is a painting from 1546. So let's see what we can do about this. So I will follow this scheme for my presentation, and I will start defining the changes in cognition with normal aging. Those involve, preferably, those quick processes that are involved to make a decision, such as speed of processing, working memory, and executive cognitive function. All people in normal aging, they keep their knowledge and skills. This is why we always say that all people are wise, right? And it has been observed that with time, with aging, there is a parallelism between these changes in the cognition and structure changes from a structure and functional point of view in the neurons, such as the synapses or the network connections. And the cognitive impairment refers to problems with learning and memory. This is a pathological situation in which as people have problems with attention, perceptual motor cognition, problems in recognizing people, interaction with the environment, etc. We can talk about risk factors such as aging, the age, also the heart disease, any factors affecting the heart disease, also certain polymorphisms, genetic alterations, and also depression and physical fragility. So the diagnosis is made through historical clinical history, neurological exam, lab test, and brain imaging, like my colleague was showing, and as well as neurological test, which includes mini-mental state examination, Montreal cognitive assessment, Alzheimer's disease assessment scale cognitive. I am pointing these three because they were used preferentially in the studies we selected. So the treatment, we can talk about two blocks of treatment. One is pharmacological and the other non-pharmacological. Inside of the pharmacological group, we can talk about acetylcholine esterase inhibitors, such as denezepam, rivastigmine, galantamine, etc., NDA receptor antagonist, and just the recently approved by FDA in June, that there is this monoclonal antibody against aggregate soluble and insoluble forms of amyloid beta at Ulhem. So that is from pharmacological point of view. Well, my subject of study is pharmacology. Well, I'm not going to be talking about pharmacology. I will be talking about non-pharmacological treatment, which is among these treatments, we have physical exercise, transcranial magnetic stimulation, diet and lifestyle, aromatherapy, music therapy, cognitive stimulation, environmental modifications, communication patterns. So, as I mentioned, I will be focused on the effect on the cognitive function of the exercise. Why? Because it has been shown evidence in animals, experimental animals, or in human beings that there are certain alterations, certain modifications, such as angiogenesis, increase of synapses, higher better functioning of certain modulators, such as IGF-1 or BDNF, and there is also correlation with better cognitive functions and memory, etc. Based on this, we propose to study the effect of the exercise in two major problems. One is the mild cognitive impairment, and the other is dementia. After to see the effect of the physical exercise in the mild cognitive impairment and dementia, after treatment with exercise, we will see that we are going to address three kinds of exercise. So, we perform a literature search in this database, in PubMed, using these mesh terms and Boolean connectors, and we decided to this inclusion and exclusion criteria. Among the inclusion, we describe randomized controlled clinical trials, patients diagnosed with MCI or dementia, people above 50-year-old, diagnosed with this psychological test I mentioned before, and the patient that underwent the treatment with aerobic exercise, aerobic plus other activities, and resistant exercise. And exclusion criteria were longitudinal studies, other cognitive alterations, such as those secondary to the trauma or surgery, and we were also excluding experimental preclinical studies. The data was extracted. We performed the typical tables with the PICO format. Of course, I'm not going to show you here because that will not be illustrative at all. And we decided, we defined the efficacy in terms of improvement in global cognitive status or by cognitive domains after the application of the intervention with physical activity and by applying different scales of assessment. Like I said before, neuropsychological test. There was not any any radiological test. It was just through neuropsychological test. All right, and then we started selecting 300 articles, and after applying our criteria, selection criteria, we ended up having 14 articles. Well, that involved analyzing like 2,000 patients divided into the treatment group, like 1,200, and in the control group, those who didn't receive the exercise treatment. The size of the group will vary between 17 or 300 patients. Like I mentioned before, everybody was above 50-year-old, and they were diagnosed either with MCI, dementia, and then there were a pool of patients, two articles, in which they pooled the patients in MCI and dementia without dividing. So, well, this is just a scheme to clarify the way I'm going to present the results. First of all, I'm going to present the results of those papers who treat the cognitive disorder in a global way. Then we present those by domains, and inside of this, we are talking about MCI plus dementia, and finally the dementia. And inside of each group, we will divide by the kind of treatment, either aerobic, aerobic plus other activities or resistance exercise. So when we evaluate the cognition disorder globally, we can tell that we found 83% of articles, like did it in this way, which represented 54% of patients. So 54% of the patients that we included in the whole study received an improvement in his cognitive activity, in cognitive activity, by applying the exercise. Then, when we talk about the articles who studied the cognitive function by domains, understanding by domains each one of these functions, such as function mobility, recognition, concentration, language, attention, memory, etc. We will classify, first of all, mild cognitive impairment. These are the articles that got benefit in these domains. The domains are color-coded, and this is represents the percentage of patients who receive benefit in these particular domains. And among these, we are going to classify, I think I skipped one. So these are the articles for the mild cognitive impairment. This is the percentage of patients in total. And then among of these patients, we are going to classify by the kind of exercise. So aerobic exercise, the patients will get the benefit in most of the domains. But I want to point out that the highest percentage will come from memory and global cognition and executive function. The same thing applies when we analyze the resistance exercise. But in this context, we get less benefit as far other domains, right? Then, when we analyze the mild cognitive impairment plus dementia, we were able to pull just 2 articles, and those 50% of the patients got benefit from the global cognition as well from executive function. So as it seems like it's something that gets repetitive, cognition and the global cognition executive function. And finally, when we analyze dementia, we were able to gather just 3 articles, and these are the percentage of patients who got benefit from different domains. And if we stratify by the kind of exercise, when we analyze the aerobic exercise, again, we observe that the executive function and the memory and the global cognition were those domains that got better benefit. The patients got better benefit. The same thing applies with other activities. But again, like I was showing you before with the MSI, in the dementia, the aerobic exercise, the patients receive better benefit in comparison with the rest of the exercise, in terms that there are more domains in which the patients get better outcome, right? So I would like to point out certain aspects of this work. First of all, there is heterogeneity as far as the kind of exercise people were performing, as well as the length of the treatment, and that will explain the short or long-term effects. I must say that physical exercise significantly benefits memory, global cognitive capacity, and executive function in patients with MCI and dementia. But MCI saw improvements in comparison to the control in the greater number of cognitive functions, unlike dementia, we show less. And the aerobic physical exercise is the most effective activity in MCI, like I mentioned earlier. And I would like to point out this intervention is not invasive at all, like it could be pharmacology, right? So it's highly recommended. And we have to keep in mind that also these studies are underestimated by the fact that these people, since are old, sometimes they will not adhere to the treatment very easily, and sometimes they will consider like the neurological test a little frightening, as opposed to be analyzing in a free way when they are doing daily activities at home. So my conclusions are among the different physical therapies, aerobic activity is the most effective treatment for both mild cognitive impairment and dementia. The cognitive domains that are most favored after the application of aerobic exercise, both in mild cognitive impairment and in dementia, are memory, global cognition, and executive function. Physical activity as therapy for cognitive disorders has few adverse effects. It is necessary to carry out more randomized control studies stratified according to the type of cognitive impairment and health status of the patients, neurocognitive tests used, and type of physical activity and duration of treatment. And this is the bibliography. And I will leave you with this question. Is exercise the elixir of eternal youth? Thank you very much. I'm ready to take any questions.
Thank you very much, Marina. Very instructive. You know, it confirms somehow the Latin words that mensana
corpore sano.
in corpore sano, yes. And now we have the scientific proofs for this. If there are any questions from the audience? Yes, you did, except the questions, but that's another discussion. Well, now let's move to the University of Coimbra. We have a communication elaborated by Professor Paula Santana and Assistant Ricardo Almendra. Now it is with us Ricardo. Please, Ricardo, feel free to talk to us about the effects of environmental conditions on aging. Please.
Good afternoon to everyone. Thank you for the introduction. Some disclosure before we start. My presentation, or our presentation, is going to be slightly different. It's going to be way broad, and it's going to give you some insights of what our group is doing, how we approach lifelong, how we approach healthy aging. Just a short view of the team. This morning we were talking, someone talked about gender equality in research. Please take us as to the case. As you can see, I represent the male minority in our research group. We often work with health inequalities, geographical factors influencing health and health equity, and also participative governance. Before I actually start my presentation, what brings me here, please just keep in mind the presentation of Marina before and the role of physical activity, and I will go back to that later. Now, we are living in an aging world. It's not new. We have heard this since the last years. We in this academia, we have learned this before the politicians. We have heard this for very long. But currently, there are a couple of countries with near 30% of elders. But the estimation for 2014 show us that almost all European countries will have more than 1/3 of elderlies. As you can imagine, this is a good thing. This is good. We are living more. But we are living in an aging world with challenges and inequalities, and that is the dangerous part of it. We know that life expectancy is different. We can see in blue men and in red the life expectancy of women. We can see how it changed from country to country. This data is from Europe, every new. But now you can see how different life expectancy is with incapacity and without. In darker color is healthy life expectancy. Well, you can see that as a Portuguese man, I'm very unlucky. And I'm even more unlucky because once I arrive 65 years old, I'm expecting to spend the majority of my life after that with some degree of incapacity. And this is something very serious. Curiously, in Portugal, women are expected to live way longer, but their healthy life expectancy is shorter than men. Of course, this is not only biological, this is related to lifestyles and to history. I'm going to go back to that after. Also, there are inequalities within our cities. We did one exercise for Lisbon metropolitan area. You know, the exercise that is known have been done in a lot of cities, where you measure life expectancy in all metro stations. And we can see that through the blue line, there is a 6.2 years gap in life expectancy. People living here are expected to live almost 81 years old, and here 74, in just 8 kilometers far away. I invite you to see a video explaining this, a video much more showing how people live than on scientific, on the process of calculating. Also, allow me to do some advertisement on our platform with data from this European project. The data is available, is for free. You are invited to use it, and you can find it on that link. So, we live in an aging world full of inequalities, and we aim to have a healthy aging. And our current state of health is just cumulative of everything we did previously in our life, and also a bit of what our parents did in their own life. For instance, if our mother smoked or was supposed to smoke while she was pregnant and so on. But now I bring back the physical exercise that Marina mentioned, and between other factors. If you spend our childhood in a cold house, it's not the same if you live comfortably. If we work in an environment that exposes to pollution, is different if you work in a healthy environment. And not to mention other aspects of our social life. In fact, we start to grow older since the day that we are born. Our functional capacity tends to increase, if everything goes as normal, until a certain age, and then decrease. But the rate of decreasing is different. It decreases faster for some of us. Some of us don't even reach the top of their potential, and then we arrive to the end of the life with a larger disability. So our objective, our goal should be to decrease this gap. Of course, based on what I said before, we cannot only focus when we are old. We need to work throughout our life. But where to act? How to achieve this? Well, in urban spaces. It is where we live. It is where we spend majority of our time. These images are from our city. Not all cities are flat as Salamanca. We live in a very hilly city, but it's difficult to live there, not only for elders, but to everyone. In some parts of the city, where is it? There are no sidewalks. Other parts, they develop some support to help people going up or down. In others, still didn't. Steps for some people are difficult, or even for us when we are carrying a larger bag, and so on. So we need to build spaces for a healthier life. We need to build spaces that allow us, that encourage us to practice physical activity. As Marina said, it has strong health impacts to our lives. But if you live in a place where we don't feel safe to go outside, most likely we are not going to do physical activity in the street. So the environment where we live, the place where we live, impacts our choices, impacts the way that we are getting older. We also need to grant access to healthy food. We need to find a way that make people be in contact with the nature, but also we never forget the social part. Humans need to interact with the other humans. We need to favor that environment. We need to build spaces that favor that interaction. Now the key question, how do we act? Well, in theory, this is very easy. We know the solution, or the solution is pointed at by several documents. We need to ensure good transportation, good housing conditions, social participation, respect, social inclusion, civic participation, employment, information throughout community, community support and health services, outdoor spaces, in building quality, and so on. But how can we actually do it? Well, I can tell you what we have been trying to do in the last years. We do our research, we do multidisciplinary, transdisciplinary research, and then there is a time that we need to approach the stakeholders. We need to approach the people that are in the field, the people that live in the urban areas. We need to hear their opinion. We cannot build up top-down policies. We cannot build up top-down measures. We cannot just arrive to a neighborhood and say, your neighborhood needs a green space, and we tear down a building without knowing how important was that building. We need to know what people want, what people need. And also, we cannot ignore people that do their living in space, people that have their stores, the landowners, also NGOs, of course, and the municipalities, the legislative power, institutions that have the power to intervene in the field in our city, and also, of course, the police, in between others. So there is a question, which city do we want for the future? Which city do we want for our children, for the children to come? And what are we going to do for it? Do we want a greener city? Do we want more walkable cities, more integrative cities, more near, where everything is nearby? What are we going to do in order to achieve that? How can we build that? And I think that's also what we are doing within this project. Thank you for your attention.
Thank you very much, Ricardo. Well, I can conclude that if we are associating the old age with wisdom, in 2040, our society, globally speaking, will be more wise than today.
Let's hope.
hopefully well. If there are any questions from our friends online or from the room, because we are a little bit under time pressure, please, a short one.
I will say the questions. Our colleague was asking if I have some suggestions, some example of age-friendly interventions taken to make a more age-friendly space. Actually, our cities are full of these interventions, and let me state again, age-friendly towards the life. But there are not solutions that you can apply them to all the cities without knowing where you are applying them. Being this, in Coimbra, for instance, there have been a lot of activities made to improve the quality of life in the city. For instance, one thing that has been done in Portugal, not only in Coimbra, that just came to my mind, majority of elderly in Portugal have problems with mobility. at least in Portugal, I'm speaking of what I know. And a lot of municipalities have created driving services that you can call them, that people can call them, and they take them for free or for lower prices, but it's something institutionalized to take them from their door, for instance, to the hospital. And there have been a lot of activities also regarding social interaction to guarantee that they leave the house, they are in contact. So there are a lot of initiatives in the different dimensions of age-friendly cities that they have been taken and applied, and I can share more of you after. But again, they should not be applied without listening the people that are living and who are supposed to benefit from it. And that is a good example. I also knew that.
Well, we are a little bit under time pressure, but this evening, I guess, yes, we have a Spanish wine welcome dinner, so you can continue this discussion. You are free to do it. Well, right now, let's make two changes. The first one is that we are moving from on-site to online communications, conferences. And the second one is that we are changing the peninsula. From the Iberic Peninsula, we are moving to Italy, another peninsula, at the University of Pavia, and we are inviting Professor Rosella Napi to conference about menopause as a turning point in healthy longevity in women. Please, Professor. Maybe it would be better for us to change it. We are afraid not to. Okay, thank you. Thank you.
one. We have to consider all these factors and why, for example, a symptom of hot flashes is so important. And I'm sharing this experience with you, because we know that women that suffer from this symptom, they are more prone to long-term conditions such as cardiovascular disease, osteoporosis, and even cognitive impairment Marina was talking about. So in essence, a symptom that seems quite trivial, it just you have a little bit of hot, we know that is a red flag, is we may say a hallmark of a vulnerability during the aging process, because for sure that all these conditions, cardiovascular disease, osteoporosis, and cognitive impairment, they will not occur around 50, but they will occur long after. Go next. And indeed, this is my view of what we should study together, because we know that life expectancy increased. We know Ricardo showed us very well. But keep in mind, please, that age at menopause stay stable over time, because as a very important adaptive significance, we don't have the time to talk about that. But when we handle this window of vulnerability around the age of 50 to 60, and we try preventive strategy, including not only medical treatment, but what I'm looking for, it's really including behavioral and social strategies, we can really reach a very important goal. That is the goal of healthy longevity, so well. So trying to spend a longer period of time in good health without disability. And this is in essence, go ahead, next slide, what we should work about to try to understand, because we know that what is occurring during this period of transition and beyond, between 50 and 60, it's really affecting all the system that we now study in the context of geroscience, because we know that this change will affect, on one hand, the aging biology and also the aging physiology. And next slide, please. This is the concept I want to close, because it's very important that we consider in our studies the time women are exposed during their life to the most important hormone for them, that is estrogen, because as you can see that the two most important event in a woman's life, that is menarche, so the first menstruation, and the last menstruation, that is the age at menopause. Go back. This is a famous, go back please, here, will affect really what will happen in terms of diseases. Because if you have a short period of your life in which you are exposed to estrogen, you can develop more of some condition. If you are exposed longer, you can develop less. And of course, we don't know if this is a question of gene, if it's a question of hormones, or can be a question of lifestyle and other aspects. Go ahead, and we are almost at the end. But just to convince you that this is true, you see, this is a wonderful study that was performed in the United States, in which they compare the women that live longer, age 90, to women that live less. And you see that the odds of longevity were 13%, small number, but is significant, higher in women with more than 40 years of reproductive lifespan, exposure to hormones, compared with less than 33. And this is important. Why? Because we know that we have a wonderful model we can study together that is premature entering the menopause. Why this is? Next. Because this is the first study that was published in Proceedings of National Academy of Science, in which they made a very simple experiment trying to study the epigenetic role of entering menopause early. And you see, briefly, that there is an increased epigenetic age acceleration when you enter menopause early, due, for example, to oophorectomy, so removing of the ovary. And therefore, what does it mean? That the time we enter menopause, it's very important, because we have many biomarkers of the biological aging, they are correlated to this condition, and not only the age, but of course also the symptoms. We don't have the time to go into this. And so in conclusion, I really believe that we have to consider menopause as a natural phenomenon, because this is it in women's life. But if it's occurred prematurely, and in those women, they are prone to develop a lot of symptoms, this is really the door of an aging process we can work together on. And next, we can do a lot, of course, as doctors, but remember that primary prevention, healthy diet and lifestyle, and controlling throughout all the strategies we have in our hands, risk factor for health, it's very essential. So dealing with this period of women's life is not only prescribing treatment, but it's really doing a job that is a sort of re-education of the woman. And it's important. Of course, you start when you're young, and we should understand better this point in research, but you can do always something. And I believe that we should study really this from the beginning of our life to the end, but we have to put together really our competence. And I'm very pleased to be working with you in this work package. Thanks a lot for your attention.
Thank you very much. Thank you very much, Professor Napi. If there are any questions, short ones, please. Otherwise, let's move to the next speaker, or rather speakers, because we have a team. We have Professor Rüdiger Trimpop from the University of Vienna, who's online. Can you hear us, Professor?
Yes, I can hear you very well. Can you hear me?
Hello, how do you do? Yes, great. It's a great sound.
How
do you do? Welcome. And he will be represented, the professor will be represented here together with us by his PhD student, Lena Schmidt. Am I right? Well, Lena, please, and the subject of your conference, as I can read here, is Healthy Campus.
Yeah, I would like to start with a few introductory remarks.
Great. This would be great. If you want to start, yes, of course. Please.
With a few introductory remarks, and then Lena will take over with the actual presentation. This approach that we have here is of a very different kind. What we do is we do research and propose research, but on us. Of course, universities are just as well organizations where people are aging and where prevention should start very early for all kinds of health problems. And so we have designed an approach where we can put health, prevention, and all of that into all different groups of the universities. And we have designed a questionnaire and approaches and also methods how to convince our presidents to take part in that and to give money and so on. And what we would like to do is to offer this as a common research ground for all of our universities. We would give you the questionnaires, and you can translate them in whatever language you want, and we will change all your suggestions into the approach that we have taken so far, and thus develop a common measurement tool that we will then use everywhere and can have a wonderful instrument to have comparisons of different cultures, different structures, different eating or living habits, and that over time again and again. And what we can do is also take that as a basis for, let's say, a master's program that would look at the different programs if we get an extension on this whole process. So this is the kind of suggestion we do. And what Lena will present now is how we approached all of that in our university. And I'm honest with that. If we can be of any support for you introducing that, of haggling with your finance department or in changing the questionnaire to the local specific needs or analyzing the data, we are very happy to do that. And it would be wonderful if we would have a common tool with all these countries to make long-term international comparisons for the concept of a healthy campus, because the people, the students are young and healthy in the majority, but us, the staff, are more older and less healthy. So the combination there would offer kind of a playground for all of the different approaches. I'll be there for the questions again, but now I leave the stage for Elena.
Thank you very much, Professor. Lena, please, if you want to stand up and conference from there, that would be great. Okay, as you feel comfortable.
All right. Hello, everybody. Buenas tardes. It's a pleasure to be here with you. Thank you so much. My name is Lena Schmitz, and I'm going to represent the team for the Healthy Campus from British University Jena. We're actually a team of 3 different teams from the university, which is not only the Department of Industrial Work and Organizational Psychology with Professor Trimpop, Julia Hoppe, and myself, but also the Student Health Management and the Occupational Health Management. So we're like a 3-part kind of team. Yeah, I'm just going to go quickly over this and give you a quick introduction to the contextualization of this project. Of course, there are always legal requirements concerning occupational health. And in Germany, it's the case that healthcare providers in Germany are actually obliged to take care of prevention and of health topics in the work context. And that means that we actually really have to take care of mental and physical health in university context for students as well as for the university staff, because as you can see, a lot of students face like a lot of stress while they're studying, and the same counts for academic staff. They face multiple work-related issues such as temporary contracts, working overtime, job uncertainty, topics that most of us might also be familiar with or have been familiar with in the past. So the goal of the health management should be to create a health-promoting university environment for all of the actors, students and employees, and to strengthen individual health resources. And as Professor Trimpop has already mentioned, we have a very holistic approach on that. So we're going down from the legal requirements, and we actually want to broaden this topic and implement a culture of health in our university, which would be represented by the Healthy Campus project, which is actually an integration of the occupational health management and the student health management, and then like actually goes down to the individual students and employees. And as our colleague Ricardo has also said, we have to ask, okay, what do we need? And we actually have to engage with the people that we want to work with. So that's why we created a student survey and a university staff survey, from which we want to take basis for implementation of interventions and offers for students and staff on healthy working and studying conditions, which we of course also scientifically evaluate afterwards. So the theoretical frame that we propose for this to actually have a holistic approach on this is to display the interaction between organization, work environment, and the person, which is a model called Hope's model, as you can see on the slide, by Professor Trimpop, which highlights the interaction between all of these different components and actually have an impact on the psychophysical health and the success of each individual person. The interesting point of that is that we are actually considering the reciprocity. So we have a very holistic point of view, which is also displayed in the survey that I'm gonna present now. So the university health management, as I've already mentioned, consists right now of the student health management and also occupational health management, which is for students and staff. And the ultimate goal would be to create all of this into a university health management, which would ultimately be the Healthy Campus, so that all actions of University of Jena are combined in one working unit, and there's a lot of communication to actually implement the interventions. So far, there was already some actions because they were really needed. So for example, there are offers on stress management, healthy studying methods, or also sport programs, which most of the universities are probably also familiar with here. So the idea is to actually use the data of the surveys that we are conducting right now or have conducted already and complement these interventions with more actions that are actually reaching the individuals as they need it. Here's some more information on the instruments that we are developing or have developed and that we would also like to propose to all EC2U partner collaborations to use them also in the universities. It's an adaptive questionnaire with more than 800 items. It sounds a lot right now, but it's not because it's an adaptive instrument. So we have screening questions, which then go into more detailed sections. So it's a very personal kind of approach and survey. We are, of course, following this holistic approach to health. So we're not only talking about exercise and nutrition, which may be the first thing that come to mind, but also social health, psychological health, work-life balance, studying when you have children, etc. One very important feature is that each participant gets an automatically generated personal feedback on the different health areas. So this already creates awareness for the participants and keep them engaged in the topic of health. Oh, and of course, we are also going to communicate the results for the different departments so they can also implement interventions. So the survey process was a big collaboration with a lot of different actors, mostly students and experts of Iulian, which then allowed us to create a database of the survey with more than 2,000 student participants. We're very proud that we have reached a 10% participation from the population, and the same goes for the pilot study for the staff survey. We have already 100 participants, and the ongoing staff survey with more than 1,000 participants already. So we can see that this is also a topic that people really want to engage in and that we can have a communication with the target group. All right, some preliminary results on the student survey already show the first need, which in case of the students is a lot of psychological need for support, especially in reducing stress around the exams. I guess everybody can relate to that. But also another topic that may not be that visible is balancing financial resources, like working while you have to study, or studying with a credit, and also at the same time meeting the university requirements. And the results for the pilot study for university staff show a slightly different pattern because, of course, the financial topic might not be that important to them, but other than that, ergonomics of the workplace is a more important topic, and working hours, for example, to have to be working overtime, especially in academia. So we are actually looking forward to have more further data analysis on the university staff in November, because that's when we conclude the study. All right, thank you so much so far. I'm going to go back to my professor, Trimpa.
Yeah, thanks a lot. Could you go on this slide? So the theoretical part, of course, is that we will have to do with that many people, we can do a lot of interaction questions, like what combination of stressors lead to what kind of physical and psychological problems, which is normally not really there. And with the staff, we have a within subject longitudinal design, which gives us really good data. And with the students, we have at least a between subject longitudinal design. Well, if they are longer at the universities, we test them on average every 2 to 3 years. With the international component, it would be even better, because then we have a comparison. The structures are very much the same, young students, older staff, and the working conditions are different. So we would have an international natural laboratory where we could look what works, what doesn't work, what are the threats, what are the solutions. And we could also publish the data together and the results and make a real impact for other universities in other countries who go into that as well. Yes, could you go on, please? Yeah, the relationship to GLADE is very obvious there, that we all can benefit from that. And I guess at your universities, some problems might be the same as in Jena. Very often the courses for health and safety and so on are visited by the people in the administration, but not by the researchers. They are not reached, they don't really go into that. And here we include that researchers and students offer courses for themselves and our group. So it is intertwined. Research, teaching, and so-called administrative duties. They're all intertwined. Also, the research staff can take part in PhDs and masters and so on in having some benefit from doing something for their own health and that of our whole community. So we hope to have a very different motivational approach than if there is a homepage where the health office of the department of the university says, well, if you can take part in this jogging course, it will be good for your health. So we really want to intertwine it so that everybody also has the cultural feeling we all work for our common health. And if you want to participate in that, it would be just wonderful to go ahead with this idea, and we would have a common ground and a lot of data to look at, analyze, and publish as a common project of our group. Thanks for your attention.
Thank you very much for this duplex, Professor Trimpop and Elena. Well, you deserve our applauses. And I'm sure that all the universities will be interested in your work, and congratulations for this. And now let's move north to Christine Sursa from University of Turku. Are you here, Christine? Can you hear us?
Yeah, good afternoon.
Hello, hello. And we have research subject, changes in physical activity and sedentary time across the transition to retirement. Please, Christine.
Yeah, so the aim of this FIREA study was to examine health behavioral and clinical risk marker changes during the retirement transition and long-term consequences of work and retirement on health and functioning in old age. Yeah, next slides, please. Yeah, so the study population included Finnish public sector workers whose estimated retirement date was between 2014 and 19. And the mean age at baseline was, the previous one. Yeah, the mean age was 63 years, and in Finland, the public sector is very female dominated. So 80% of the study population are women. And this FIREA study has a larger cohort and 2 sub-studies. And this larger cohort has responded to a questionnaire about work factors and health behaviors, and it has been conducted every year after 2013. And within this larger cohort, there is an activity sub-study, which includes 900 study participants, and they have worn a wrist-worn accelerometer every year after 2014 to get more accurate information on physical activity, sedentary time, and sleep. And today I'm going to talk about this activity sub-study. But we also have this smaller, the last one, the second previous one, yeah. We also have a smaller clinical sub-study which has also the clinical health outcomes in addition to accelerometers. But today I'm going to talk about this activity sub-study. Yeah, next one. Yeah, so in this activity sub-study, the study participants have worn a wrist-worn actigraph accelerometer for 1 week every year before and after the retirement transition. And they have also filled in a daily log in which they have marked their sleeping times, working hours, and the actual retirement date. Next one, yeah. So this actigraph accelerometer measures acceleration in all 3 dimensions and forms this kind of summary measure, as you can see in this picture. And we use different kind of algorithms to detect sleep and non-wear time, so that we can get physical activity and sedentary time from wakeful hours when the accelerometer was worn. And here are the main results from daily total physical activity. Yeah, you can click 3 times now. Yeah, one more. Yeah, thanks. So in this, we see all the measurement points and the level of daily total physical activity. And we saw that the main changes were among women who retired from manual occupations, so service and physical work. So their activity levels decreased during the retirement transition. And among other groups, there were no marked changes, but we can see that women were more active than men, and manual workers were more active than non-manual workers. And also, among men retiring from non-manual occupations, we can see that there is this slight increase in activity during the retirement transition, but it's not long-lasting. Yeah, next one. And we also looked at the activity levels in each hour of the day. And yeah, you can click one. Yeah, so we see that the main differences come from working days and the usual working hours, so that manual workers are more active than non-manual workers. And on days off, the profiles are a bit different than on working days before retirement, because there is only this one activity peak during mornings, and after that the activity decreases. And we can also see that after retirement, the profiles are almost similar as on days off before retirement. Yeah, then next one. And then the sedentary time, in this we can see that men are more sedentary than women. They have more daily sedentary time, and the marked increase in daily sedentary time can be seen among women who retire from manual occupations. So their daily sedentary time increases about 1 hour per day. Yeah. And as a conclusion, we can say that physical activity decreased and sedentary time increased among female manual workers. And among male non-manual workers, physical activity slightly increased after retirement, but it was not long-lasting. Yeah, and here is our research group. And yeah, and if you want to read more about the FURIA study, you can visit our website.
Well, thank you, Christine. Many of us hoped that after the retirement we'll sleep more, but it seems that we'll have more activity, at least physical. Now, applause for Christine. Well, with your permission, I've been told that the coffee is ready, but unfortunately it's too hot. And please, if you'll have patience, if you'll be patient for 5 minutes to get the coffee to be drinkable. And meanwhile, I invite Professor Daniela Soitu, my colleague from the University of Iași, to present the communication paths and challenges of GLADE Virtual Institute. Please, Daniela.
Thank you very much, Professor Damian. We had the opportunity today to meet the director of GLADE Virtual Institute, our Vice-Rector, Professor Iulian Damian.
Doesn't function.
Doesn't function. Okay, we will quickly go to a reminder for some of you of the main activities. And also I wanted to share that everything we have been done is a result of a team, a huge team, an international team, national team, participants. This is the local small team. We say hello to the participants from University of Salamanca, to the summer school. As I know, you had enjoyed this event, and it's our duty to show that we very much appreciate it, as you have done, even in the evaluation and activity after that. You had received 3 credits. Okay, it seems that there are nice memories at the end of the summer school. This is the frame of the presentation for each researcher participating in the virtual institute. We are almost ready with a study related to the lifelong well-being and healthy aging. Allow us to invite you to the first GLADE conference in less than 2 weeks. Thank you, Christine, for launching the co-tutel for PhD thesis. We were happy to have 9 applications, from which at least 3 are co-financed, and we could saw the interest among the researchers from our 7 universities. We know about the events related to online peer counseling lab for students. We will be sure that the link to the Lyme survey will reach all of you, all university, in order to provide this counseling support services. This is a screenshot from the first workshop presenting the practices of the international relations offices in supporting the students. And some of you may recognize in this one, during the second workshop, when students presented their, student and student associations presented their contributions to in relation to the counseling and supporting their colleagues. These are many things wrote. We will have to do everything from here in 2 years. All the contributions are welcome. And this is the larger local team from the University of Iași. Many of them are involved and were being involved in designing the National Lifelong Wellbeing and Healthy Aging Master Program. And you know how we are at this time related to this master program. And actually we are happy with everything we have succeeded. I haven't mentioned before, we are working on a web page for the Virtual Institute. And as soon as it will be ready, we will share it with all of you in order to share the joy of common achievements. Thank you very much.
Thank you very much, Daniela. Well, as you can see now in the Virtual Institute of Iași, we are for the moment more focused on activities with the students and the community activities. But as a conclusion, as a general conclusion, if you allow me, we can notice that all virtual institutes have a very serious research component. So I think through these institutes, this research component will be offered to the community sooner or later in the benefit of all of us. Right now, with 9 minutes later, the coffee is perfect. So enjoy it. Thank you very much for your time, and thank you very much for your very interesting communications. And again, applause for all the team.
And thanks for organizing it so well. also the mixture, the hybrid conferences are very difficult. So you did an excellent job. Thanks a lot for that.
Thank you. Bye.
Thank you. Goodbye. Thank you. Thank you, my dear friend. I hope you have coffee too.
Cheers, but it's cold.
Cheers. Cheers.
Thank you very much.